I'm Peter Block here at the AHA annual meeting in Chicago for On the Scene, and with me is Dean Kariakis. Dean needs no introduction. He's from Cincinnati, an accomplished trialist, and we have been talking about dual antiplatelet therapy, but Dean now has the inside track on the DAPT trial. So Dean, rather than go over the whole trial, let's talk about what this really teaches us.
Yeah. We have two sets of analyses, one presented by Laura Mori and the 9,961 drug-eluting stent patients that were randomized between 30 and 12 months of thienopyridine in combination with aspirin. And these randomization occurred 1 year out. So patients had to be MACCE, that means death-MI stroke, major bleed free, and DAPT compliant at 1 year in order to get randomized. And the stratification of randomization in the DAPT trial also included stent type, DES or BMS. So we have 1,687 bare metal stent patients that have the same randomization to extended 30 months versus 12 months of thienopyridine in combination with aspirin. On top of that, what I'll be presenting as part of the bare metal stent analysis is a very sophisticated prospective propensity match analysis in 10,026 very tightly matched subjects that were DES or BMS. And so we did that because we wanted to see what were the relative rates of stent thrombosis in Mackie in tightly matched on 55 variables, perfectly on the variable of STEMI, and with a 10% caliper, a 0.1 caliper on the other 54 variables. What's the incidence of stent thrombosis in Mackie in the DES compared to the BMS? And then is the treatment effect of prolonged therapy similar or consistent between the two stent types?
Well, let me just ask you the question, because obviously the myth is that bare metal stents, do better, and drug-eluting stents take longer and all that kind of stuff. So what did you show?
Bravo. It is the myth of the bare metal stent. I can tell you that the stent thrombosis rates in DES were significantly less than those in BMS in a period of 0 to 33 months, the entire period of time. From the index PCI and the propensity match, we actually followed all enrolled patients that had at least 29 months of follow-up. So we went from the index procedure with a 3-day blanking period for myocardial infarction forward to 33 months. There's a highly significant difference in lower stent thrombosis rates with DES compared to BMS. And then in the randomized cohort, we found that the treatment effect of longer therapy reduced stent thrombosis by 51%. The hazard ratio is 0.49. We did a treatment duration by stent type interaction with the DES randomized, which has a 0.29, so you're both under 0.5 hazard ratios, greater than 50% reduction. P-value for interaction 0.42, Peter. So there's hazard ratios under 1, no interaction. It appears that the impact of long-term therapy versus shorter therapy is consistent across the stent types. So why put in a BMS at this point? I don't have a good reason.
Well, Dean, you're sort of turning everything on its head, aren't we here? And it's interesting to me because it implies that maybe something else is going on. Maybe we're treating the patient rather than the stent. What are your thoughts on that?
Absolutely. The two things I take away is, number one, some of these polymers are actually thromboprotective, meaning the polymer coating, like we saw in the examination trial, different trial, which had Xience versus Vision. You had a higher rate of stent thrombosis in the bare metal Vision stent, which is the same stent platform. The polymers appear to be thromboprotective. And secondly, in Laura's analysis yesterday, dramatically 55% of the heart attacks that were prevented by long-term therapy, that's 1.1 out of the 2% absolute difference, were not related to the stent. This is, I think of dual antiplatelet therapy, believe it or not, now as similar to a statin in patients with symptomatic atherosclerotic cardiovascular disease, similar to what we saw in Charisma symptomatic group, similar to what we saw in CURE, even without the PCI. I think these patients should think of their dual antiplatelet therapy, unless they have bleeding complications, unless they're not tolerated, similar to what they think of their statins. And when I place stents in patients, my intent is, if it's tolerated, to keep them on dual therapy long term.
Okay, so there's a teaching point that's a rather new one, Dean. Thank you. And it seems to me that, if I had a stent, I'm not so sure I wouldn't just keep on dual antiplatelet therapy as long as I didn't have a bleeding problem.
Right.
Take my statins and hope that, in fact, all of this stuff was treating me rather than my stent.
At the end of the treatment period, 30 months, those curves are divergent. Franz van der Werf pointed that out on the stage. And the question is, if we had continued it longer, we'd see even greater delta, is what it looks like.
Take your dual antiplatelet therapy. Thank you, Dean.
You're welcome, Peter. Thanks for having me.